The care of young febrile infants is complicated because some of those well-appearing febrile infants may have a can't-miss invasive bacterial illness, such as bacterial meningitis or bacteremia. We routinely check for UTIs in these infants because UTIs are so frequent, occurring about 8% of the time.
But who has bacterial meningitis or bacteremia and who doesn't is a big question. And if they have a UTI, does that change the risk of having meningitis or bacteremia? Our main question was if a febrile infant younger than 2 months of age has an abnormal urinalysis suggesting a UTI, do they really need a lumbar puncture or even blood work? So to answer that question, we performed a secondary analysis of more than 7,000 febrile infants in the first 2 months of life who were enrolled between 2008 and 2019 in PECARN studies to evaluate novel biomarkers for invasive bacterial infections such as meningitis and bacteremia. We considered a positive UA by the presence of nitrites, any leukocyte esterase, or more than 5 white blood cells per high-powered field. We used standard definitions for UTI, bacteremia, and bacterial meningitis. Based on the previously derived and validated PECARN SBI prediction rule, we considered absolute neutrophil count, or ANC, less than 4,000, and procalcitonin, or PCT, below 0.5 to be normal. And we evaluated the risk of meningitis and bacteremia in those with positive and negative urinalyses. We also looked at how the ANC and PCT modified the risk.
Our results revealed among the 7,180 infants, 15% had positive UAs. The risk of bacterial meningitis was 1% in infants 28 days of age and younger, no matter if the UA was positive or negative. The risk of meningitis was the same no matter what the UA showed in the first month of life. This is key. But more importantly, amongst the 697 infants in the second month of life with positive UAs, there were no cases of bacterial meningitis. Let me say that again. No cases of bacterial meningitis in infants with positive UAs in the second month of life. In comparison, in the same age patients with negative UAs, 0.2% had bacterial meningitis. The risk of bacteremia for those with positive UAs was 6% versus 1% in those with negative UAs. However, there were no cases of bacterial meningitis or bacteremia in the 148 infants younger than 60 days of age with positive UAs who also had normal ANC and PCT levels.
As a possible limitation, we recognize that our study was conducted at large children's hospitals, not in pediatricians' offices or in general emergency departments. And although we studied a big population, when you're talking about the risk of a serious illness like bacterial meningitis, the study could always be bigger.
So the answer to our main question of whether febrile infants with positive UAs routinely need a lumbar puncture, our findings suggest that febrile infants with positive UAs in the second month of life do not routinely need lumbar punctures. But in the first month, they do.
And do they need blood work? Although we found the ANC and PCT to be very helpful in identifying those with meningitis or bacteremia, our numbers for that analysis were not so big, and bacteremia occurs around 5 to 6% of the time in febrile infants with positive UAs, so I would still do blood testing and get the blood culture.
We hope this information informs your practice. It certainly has informed our own care of febrile infants.